I was diagnosed with a carcinoid tumour back in October 2005. The first thing I had was could be 2 years, could be sort of 4 years. By now I've had another 4 years and I'm still going strong, so I'm hoping I'm one of the ones that survives the on the longer term.
Carcinoid tumours produce symptoms because they release hormones. And in Anne's case, essentially what happens is the tumour secretes a huge amount of hormones into her system, her blood pressure drops, and if she's not attended to urgently or as an emergency, then obviously she will die.
Hello.
Hello, Anne. Good afternoon.
How are you?
I'm okay, how are you?
Yeah, not bad, thank you. I spent a total in hospital of about 8 or 9 months. After that, I went to work in hospice for about 6 weeks.
Come in, come in. How are you?
All right, thank you. Dr. John Amani came to me one day and he asked, what is it that you want to do? And I said, I want to go home. And then he said, then you shall go home.
How's your son coping?
Pretty well, actually. He's up early in the mornings, brings me my tea and toast before he goes off to work.
Okay. Hospice care is not just about the bricks and mortar. Hospice care really is about looking after people where they want to be looked after. Often it means personalising the care, and by that I mean looking at the patient's needs and saying, well, this is what we have on the shelf, and so you need a bit of that, a bit of that, a bit of that, and then we can get you home.
What I understood from personalised care is that they are fitting a service around me rather than just putting me in a box of something that already exists.
So if you put the patient in the centre, then you have to adjust your services or wrap your services around the patient, as opposed to saying to the patient, as I said, that's a service, you fit into it or you don't.
I'm a bit of a ticking time bomb if I should have a relapse and have a crisis. But because of what they've provided me with and tailored everything to me, has made it safe for me to come home.
Very often there's a perception that there isn't the same level of care in the community. And I think what we need to turn around is actually saying, well, actually the community can do just as well as the hospital, once the hospital care needs have been dealt with.
This is an intravenous pump that supplies my medication over a 24-hour period. It delivers the octreotide into me at a very slow rate, very, very accurately. And I have something called a Grotian line that goes straight into a vein down the side of my heart. This is a community alarm pendant, which has been worth its weight in gold already. From this, I can talk to a care line. If I tell them I'm having a crisis, they will straight away go away and call 999. I can remember the last attack I had, falling on the floor and laying there, breathing very heavily, thinking if I don't get to that telephone, nobody will know I'm here. All that's been taken away because this unit here means I don't have to panic.
What's best for this patient? If they're not going to get cured, surely we need to be discussing with them, that fact, but then ask, well, what do you want us to do? Where do you want to be looked after? What sort of care do you want? More importantly, what sort of treatments don't you want?
If I have a huge crisis and I don't get my drugs into me and nobody found me, I would die. I also have a DNR, which means that if I go into crisis and my actual heart stops and I stop breathing, then they're not to resuscitate.
Anybody with a long-term condition needs their care to be personalised around them. If we try and slot them into systems, it obviously interferes with their life, interferes with their jobs, interferes with their families.
Why did you so want to come home?
It's my home. There's a lot of work gone in here. Can you stop there?
At the end of the day, just being able to be a human being rather than a patient. Being able to say, well, actually, this is me, this is it. I am Anne and I'm at home with my family. Okay, I've got these gadgets that are keeping me alive, etc., etc. But I'm still Anne. It gives the patient back their life.
I'm very independent. I'm a doer, and I felt like, I guess you feel like some of that's been taken away from you. Not that they intentionally do it, because they're very good at getting you involved and you know, all sorts of activities that they do. But it's just quite hard when you think, well, I've worked for all that, but what was the point? So yeah, I want to be home with my family.
The patient's home is often the best place for the patient. For us to use hospitals the way we do sometimes, where there's nowhere else for them to be, therefore let's send them to hospital, is wrong.
When I first started talking to healthcare professionals about patient involvement, they were all very sceptical. Well, I wouldn't know how to start. They hadn't a clue. Now they are understanding that patients actually have something to give.
You'll always get that sort of doctor knows best, nurse knows best in patches, and that's the areas we need to work on.
The change in those people who've been at the centre of care planning is incredible.